Assalamu alaikum. Good morning, everybody. Thank you for the invitation to be part of this master class. I wish my talk will be optimistic like Dr. Aus, but unfortunately, the gastrointestinal tract is very, very complicated and not easy to deal with. So I'll be talking about the impact of GI manifestation on lung disease and systemic sclerosis, the guts and gasps. Have no disclosures. So through the next 20 minutes, I will review the prevalence of common GI complications associated with systemic sclerosis. We'll dig more into the common presentation, diagnostic approach, and treatment of mainly upper GI complications that will affect the lung. And finally, we'll describe the negative impact of upper GI involvement on lung disease. All right. So as you might already know, GI involvement is very common in systemic sclerosis, impacting up to even more than 90% of patients. It can affect any region of the GI tract from mouth to anus, with predominance of disorder in the upper GI tract, mainly the esophagus. Up to 10% of cases will have involvement of the GI tract in the absence of skin disease, meaning that GI manifestation will be the presenting symptoms in patients with systemic sclerosis. Risk factors, as expected, patients with diffuse disease will have more GI involvement. Myopathy, female gender, and smoking were reported as the main risk factors for developing GI disorders. Fortunately, the majority of GI complications are mild in 60%, with severe symptoms only contribute to 9%. But even if it's 9%, it's still too much because these severe GI complications were associated with increased risk of death more than 2 times. As you might know, this is GI complication is the third leading cause of death in systemic sclerosis patients, with first one being cardiopulmonary and the second kidney disease. It also, if it doesn't kill you, it doesn't really make you stronger because it will decrease your quality of life physically and mentally in these patients, with some patients reaching suicidal attempts because of the GI complications. All right, so in order, like any other disease, in order to understand how can we deal with these symptoms, how can we give our best to these patients, we need to know how does that happen? If you review the literature, the classic hypothesis that's all over the literature for GI disorders describes a 3-step process, which is exactly the same as systemic sclerosis. There is a vascular level, the vasculopathy, and there is the immunological alteration with inflammatory status, and there is an increase in fibrogenesis leading to fibrosis, which theoretically will disturb the intestinal blood flow and alter the GI contractility. But there are a couple of things that goes against this theory. First, there is no evidence that therapies approved for other manifestation of systemic sclerosis, like ILD, prevent the progression of GI involvement. All our systemic sclerosis patients, you can see them, they're on multiple medications, but unfortunately, even if the lung disease is controlled, their GI progression is rapid. And the other point is that, which this is major, autopsy studies have revealed that smooth cell atrophy rather than fibrosis was prominent in the systemic sclerosis GI tract. These areas of atrophy were not associated with significant inflammation or vasculopathy, which totally goes against the theory. And that might be the reason why there are no good treatment for GI manifestation systemic sclerosis. So now the growing evidence suggests that the enteric nervous system is the one being attacked by the autoimmune response in systemic sclerosis. The major nerve we have is the vagus nerve, which regulates the esophageal motility and lower esophageal sphincter, both of which are disrupted in systemic sclerosis. So autonomic dysfunction, which is a major thing in systemic sclerosis patient, was reported among patients with GI disease, especially with gastric and esophageal dysmotility. The interesting part that supports the theory that it's the enteric nervous system is that they noticed that there is a loss of interstitial cells of Cajal in systemic sclerosis esophageal biopsies. These cells are the pacemaker of the GI tract. They are distributed throughout the GI tract, especially in the esophagus and stomach. and they act as the pacemaker for the GI tract by stimulating the smooth muscle. So these cells are key mediator of communication between the enteric nervous system and the smooth muscle. So the fact that there is a major loss of these cells in the GI tract in systemic sclerosis also supports that it is an enteric nervous system problem. All right, so you can see here it can affect everything in the GI tract, but our focus today will be on the upper GI tract that affect the lungs. We'll spend most of the time on the esophageal involvement. So pharyngeal abnormality is reported in almost half of the patients of systemic sclerosis, and sometimes it's overlooked because these patients can have associated esophageal dysmotility, and the focus will be only on the esophageal dysmotility. The severity was correlated with the duration of skin involvement and Raynaud's phenomena, like expected. As you can see here, symptoms were more severe in patients with esophageal dysmotility and was associated with a higher incidence of lung disease. Symptoms, patients will come with choking, they have difficulty with the first to swallow. On examination, they'll see oral leakage, retention, mild moderate aspiration, and incoordination of the upper esophageal sphincter. Workup is by modified barium swallow or video fluoroscopy and ENT referral. So this is above the upper esophageal sphincter, so it's not GI issue, but it is very important, as in these patients we need to rule this out even if they present with esophageal. All right, so esophageal involvement, it is the most frequently involved organ with a prevalence of more than 90%. The interesting part is that up to 50% of patients with esophageal involvement are asymptomatic. So they might present with lung disease first, but they initially will have dysmotility of the esophagus that might be contributing, if not causing, the lung disease. All right. The first esophageal involvement is dysmotility. The presence of anti-scleroderma 70 antibodies have been associated with dysmotility of the esophageal body, along with Raynaud's phenomena, just like the pharyngeal involvement. In a cohort study, patients with positive anti-RMPC3 antibodies had more severe esophageal dysmotility than those with negative antibodies, which is expected because I think these antibodies kind of a poor prognostic factor in systemic sclerosis because of worsened lung disease. What are the main symptoms? Patients will present with dysphagia, and your hint will be it is for both solids and liquid. This gives you a hint that it's a motility disorder. They can present with chest pain, heartburn, and regurgitation. As you can see, there is overlap between the symptoms of esophageal dysmotility and reflux disease. All right, how do you work them up? First, you get a barium swallow. This will help give you an idea about the motility of the esophagus. It will help rule out other etiology. Not every esophageal involvement in scleroderma is dysmotility. So it will help rule out pathology of the esophagus. Followed by our dear upper endoscopy for better visualization to esophagus, and also to take some biopsies to rule out other pathologies. Remember, systemic sclerosis patients are on a lot of medications that has GI toxicity, so you want to also rule that out. Finally, esophageal manometry to study the motility of the esophagus and give you a better idea about the involvement. Here you can see this is a barium swallow of one of the systemic sclerosis patients. So you can see dilated esophagus because there is no smooth muscle to hold on the shape of the esophagus. You can also, thank you. You can also see air fluid level because of retained fluid in the esophagus. This patient specifically had a stricture, a peptic stricture because of reflux that worsened the disease. But this is not a typical finding in dysmotility patients. Okay, so a little bit about esophageal manometry, because I think this is really interesting, and Dr. Aus showed a lot of cool colors, so I have to show this off. All right, so esophageal manometry is a very interesting procedure. It's not pleasant for the patient because it's a catheter that goes through the nose and the patient is awake for this. But you can see pressures. You don't see swallows, you see pressures. So anything blue, anything blue, dark blue or light blue means no pressure. The muscles are relaxed. Anything yellow orange and green and red, that means there is pressure. So you can see here, we're seeing the swallow with time. The upper pressure is the upper esophageal sphincter. The lower pressure is the lower esophageal sphincter, and in between is the esophageal sphincter. So here, you see there's pressure, 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 then sudden, there is relaxation. So you can see here that the patient swallowed, because once you swallow, the upper esophageal sphincter relaxes to allow the bolus to pass. After the bolus passes, the upper esophageal sphincter immediately closes and the pressure increases to prevent any aspiration. This is normal. Then the esophageal contractions start with the proximal striated muscle and then the smooth muscle and pushes all the bolus down. Once the bolus reaches the lower esophageal sphincter, you can see here there's a drop in the pressure. The lower esophageal sphincter relaxed. So the bolus passed and immediately the lower esophageal sphincter closes up to prevent reflux. So what happens in systemic sclerosis? So this is normal, this is systemic sclerosis. As you can see, as expected, it involves the smooth muscles. So the upper esophageal sphincter and the upper esophageal part, which is the striated muscle, are not affected. There is pressure. But you can see here where the pressure of the esophagus are supposed to be, there's nothing. It's completely blue. So there is absent of peristaltis of the esophageal body. Lower esophageal sphincter is not as beautiful as this one. You can see these just point of pressures. This is not the lower esophageal sphincter. This is the pressure of the diaphragm. So it's really not doing anything. So this patient have absent peristalsis of the esophagus and hypotensive lower esophageal sphincter. When you have these two, this is the classic, what we call the classic scleroderma or systemic sclerosis esophagus. All right, so what's the relation between esophageal dysmotility and lung disease? So esophageal dysmotility, as expected, will result in poor bolus clearance with retention of liquid and food in the esophagus that leads to microaspiration. There is a systematic review that showed that esophageal dysmotility was correlated with decreased carbon monoxide diffusing capacity and interstitial lung disease on high-resolution CT. The increase in esophageal diameter correlated with great severity of ILD associated with systemic sclerosis, which makes sense. The bigger the esophagus, the more fluid and the more liquid it will accumulate, the more volume will be aspirated into the lung. Severe esophageal motor dysfunction on manometry was associated with a higher prevalence of ILD at baseline and at 2-year follow-up. So if this is not picked up early and if it's not treated or adjusted, these patients will end up with worsening lung disease. So how can we treat? After all this, we know how to diagnose, but how can you treat? Unfortunately, the worst thing that you can deal with is the nervous system. There is no way to deal with the nervous system or treat the damage that happens. So prevention is key. Early diagnosis is key. But if these patients present late, you always supportive therapy, lifestyle modification, small bites, chew food well, avoid dry or high fiber food, drink water with solid food. There's no controlled clinical trial, unlike systemic sclerosis. GI systemic sclerosis actually is the odd kid. There are not a lot of clinical data or research in these patients. There is no clinical trials evaluating the long-term efficacy of prokinetics. The experts recommend them with a C level of strength, not because they don't work. They actually work beautifully in these patients. A lot of patients feel much better on prokinetics. And if you do studies for them with barium swallow, it shows that there is improvement. It's not treating, it's just supportive measures. But the C level is because of the lack of clinical trials. And we don't know if it works with preventing interstitial lung disease in these patients. And plus, they're not very benign medications. They have a lot of cardiac complications, and they need monitoring. All right, gastroesophageal reflux disease, second esophageal involvement. It frequently occurs early, systemic sclerosis. Motility disorders will occur late, but GERD will be kind of one of the first manifestations. It is very frequent. More than 96% of patients will have GERD. Pretty much every patient with systemic sclerosis at some point will present with GERD. Severe GERD can cause complications such as erosive esophagitis, peptic stricture, and Barrett's esophagus. This is common known even in a general population. What's interesting here is their risk is way higher than the general population. So erosive esophagitis is around 35%. in general population, but in scleroderma, you can see it's 65. What's really dangerous is Barrett's esophagus. In normal population, the risk is 0.5%, can reach to 7% in countries with high risk of esophageal cancer. But you can see here in systemic sclerosis, the risk is 37%. So put them at risk of cancer on top of that, which is kind of fourfolds the general population. So why is that? Why are systemic sclerosis patients are at higher risk of having GERD, severe GERD, and having more complication of GERD? Multiple factors. As we said, they have an element of dysmotility along with GERD. So they will have weak or absent peristalsis. They will have decreased lower esophageal sphincter. The interesting part is they will have associated hiatal hernia. Why? Because with the atrophy of the smooth muscle of the esophagus will shorten and it will pulls up and will cause hiatal hernia in these patients, which makes the reflux even worse. Remember, those patients also have gastroparesis. They have involvement of the stomach, which causes even more reflux. If the food accumulates in the esophagus, food accumulates in the stomach, it's not going down, it's going to go up against the weak lower esophageal sphincter. As we said, autonomic neurological dysfunction, that's affecting the vagus nerve. And on top of that, they have associated Zika syndrome, which is loss of bicarbonate in the saliva, which is a preventive in normal population against acid. So how do we work these patients up? Unfortunately, clinical history and response to PPI is not enough. We need an objective finding in order to diagnose GERD. This is either by, we start with an endoscopy, like you can see here. The top part is the normal esophagus. You can see the pretty light pink with capillaries. And this is the transition zone between the esophageal cells and the gastric cells. The bottom pictures are esophagitis or gastroesophageal reflux disease. So what we need here in order to diagnose patients with GERD based on endoscopy is advanced erosive esophagitis, grade C and D, according to the LA, which is this one and this one. So we need severe disease in order to diagnose. Or if the patients have large segment Barrett's or peptic stricture. If the patient have any of these, we are done. We diagnosed GERD, there is no need for further workup. If the patients have normal esophagus or grade A, sometimes grade B, this is not enough to diagnose GERD, so you have to go with pH testing. pH testing is very simple. It's another we love catheters. It's another catheter that goes down the patient's nose and measure the pH in the esophagus. The number we're looking for is above 6%. Acid exposure time above 6%, which is diagnostic. Our scleroderma patients initially had grade A, I believe, esophagitis, so we had to do a pH on her, and her total acid exposure was 13.2, which is positive for acid reflux. In normal population, I would stop at this point, tell the patient you have reflux, either take PPI or get surgery done. In systemic sclerosis patients, actually, we have to go further workup. Because of association of esophageal dysmotility, these patients have to get esophageal manometry. And in my practice, I usually get also gastric emptying study in these patients. Because once you have symptoms in the esophagus, you cannot really, it's difficult to tell you, oh, I have other symptoms. I have gastric pain, I have early satiety. It's all connected. So it's better to just check that they don't have any other area involved that makes their GERD worse. So GERD is thought to be associated with systemic sclerosis ILD through microaspiration of gastric content, while lung disease is associated with worsening GERD by increasing inspiratory force and cough. So we have this cough reflux cycle. The more reflux they have, the more cough they will get. The more cough they will get, the more intra-abdominal pressure they have, the more reflux. So it's just a vicious cycle. As expected, patients with systemic sclerosis with ILD have lower LES resting pressure and lower esophageal contraction. They also had higher frequency of GERD episodes, both acid and non-acid. So the problem is not only acid reflux, it's also non-acid. And higher frequency of reflux episode reaching the proximal esophagus compared to patients without ILD, which really pretty much shows there is great association between GERD and lung disease. How do we treat these patients? Actually, with GERD, we have better research than dysmotility. Lifestyle modification, again, is one of the major things. These patients need to follow lifestyle modification. Don't eat before bed at least 4 hours, elevation of the head of the bed, avoid eating spicy food, caffeinated food, anything that will relax the lower esophageal sphincter, and review their medication. Make sure that they're not on any other medications that can cause relaxation of the smooth muscle. Pharmacological therapy, the big guns are the acid suppression medications, the PPI. Expert recommends that PPI be used to treat symptoms and prevent complications with a strength of recommendation B. There is not a lot of clinical data in PPI use in patients with systemic sclerosis and ILD, but there is a lot of literature about idiopathic pulmonary fibrosis, and those medications work because patients on PPI showed lower radiological fibrosis scores and had a slower decline in FVC and fewer acute exacerbation. But unfortunately, we cannot use that evidence in systemic sclerosis patients because these patients have an element of dysmotility that makes their reflux worse. All right, prokinetics. A study using esophageal pH impedance found that despite high-dose PPI therapy, systemic sclerosis patients had higher acid exposure time than non-systemic sclerosis control. But why? They are taking PPI because the problem is not only in the stomach. They have retained bolus. Whatever they're eating or drinking is not going into the stomach. It stays in the esophagus. Few studies assess the effect of pro-motility agents that treat acid and non-acid reflux by improving the sphincter tone and emptying, but again, showed no significant reduction in the risk of ILD. But these studies are very small, and they did not use any objective finding of GERD. So I would keep patients on prokinetic and PPI. I'm going to skip this one. What about funduplication in scleroderma patients or systemic sclerosis patients? I know it's a scary thought because these patients already have dysmotility, and you're going to wrap their esophagus and causes more dysmotility, but hear me out. I was just like that. And we have a similar patient that went through this. So we know that acid suppression alone is not enough to prevent the progression of ILD. This is supported by studies showing abnormal levels of pepsin and bile acid in bronchoalveolar lavage in patients with pulmonary disease. And there is reported symptomatic improvement and reduction of acid exposure with patients after Nissen fundoplication. But the problem with that is 71% of patients complained of post-operative dysphagia in patients with dysmotility. This is a lot. So you're treating something and causing something even worse for these patients. So if you can see here, this is the Nissen fundoplication, a full wrap. It's a 360 wrap. It's suffocating the esophagus. No wonder these patients had post-operative dysphagia. So the thought was, why don't we do a partial wrap? Started with the door fundoplication, which is half a Nissen. So you can see here it's 180 with 180 of the esophagus exposed. This did not cause any post-operative dysphagia, but at the same time was not very effective to prevent GERD because you have half of the esophagus free. And that's where Toupet fundoplication came, which is kind of between Nissen and door. It's a 270 wrap around the esophagus. So it's a pretty tight around the esophagus. It will help with reflux. But you also have a free room for the esophagus to breathe. So it doesn't cause post-operative dysphagia like Nissen. But does it work? So in patients with GERD and ineffective esophageal motility, Toupet fundoplication has been shown to be safe and associated with improvement of typical symptoms and lower rates of gas bloating compared to Nissen fundoplication. So giving these encouraging results, Toupet fundoplication has also been recommended for systemic sclerosis patients. We actually have 2 patients who underwent Toupet fundoplication that are doing well. So in conclusion, GI involvement is a common complication of systemic sclerosis, and careful history taking and diagnostic testing can identify the underlying cause of symptoms and prevent complications. There is good evidence supporting the role of esophageal involvement in worsening lung disease in systemic sclerosis patients. Addressing GI symptoms is crucial in managing pulmonary disease and vice versa. So early diagnosis and detection of these patients is very important. Management currently focuses on treating symptoms and minimize complications. So a collaboration between GI, pulmonary, and rheumatologist is essential for comprehensive care for these patients. Definitely more and better research is needed in this field. Thank you.